Worcester Hospital and a PhD in epidemiology.
Yes, thanks, Mary. Okay. Okay, thanks very much for holding out, everyone, for holding out this afternoon, and really thank you to the organizers for the opportunity to present some of this work. What I'll be sharing is really just a very preliminary effort at trying to understand the population effects of HIV exposure without HIV infection on morbidity and mortality in South Africa. So we're all very familiar with the antenatal HIV prevalence, that 30% of our pregnant women in South Africa are HIV infected, and this really hasn't changed much over the last decade. And we've heard today, and we also all are very familiar with the success story of our public prevention of mother-to-child transmission program, and that less than 5% of our HIV-exposed infants are actually HIV infected. So what this means, though, is that 30% of infants and children in South Africa are HIV exposed and uninfected. This is a substantial proportion of the infant and child population. And unfortunately, this HIV exposure, even without HIV infection, does bear consequences for these infants and children. So a recent meta-analysis done by Alana Brennan and colleagues showed that HIV-exposed uninfected infants have at least a 70% increased risk for mortality compared to HIV-unexposed uninfected infants. And this persisted across the range, the childhood sort of spectrum during infancy and as well as early childhood. And they also tried to get a sense of whether there was any change in this in more recent years with better maternal antiretroviral therapy and better programs in place. And this increased risk persisted even in the most recent studies. There's also good evidence now that these children experience an increased morbidity, particularly an increased risk for hospitalizations and experience a greater severity of common childhood infections, more severe pneumonia, more severe bacterial infections, particularly invasive pneumococcal disease, there's good evidence for, and group B streptococcus infections. And this has been observed in multiple settings and has also been observed despite better uptake now of safer breastfeeding in HEU infants. Just to very simply try to get a handle on why this might be so, I like to think of this as that these children have the same universal risk factors as all infants for morbidity and mortality. So being born preterm, being born to a mom that later dies or experiences severe morbidity, poverty, suboptimal breastfeeding, all of these increase the risk for morbidity and mortality in all infants, irrespective of HIV exposure. But we know that all of these actually occur more often in HIV-exposed infants as well. And then there are specific things unique to HIV-exposed infants. So actual exposure to the virus, exposure to antiretroviral drugs, are the things that do not occur in HIV-unexposed infants. I think we're all quite familiar with this as well, that we've seen a dramatic decline in infant and under 5 mortality in South Africa, but that this does possibly seem to be plateauing in more recent years. And putting these two trends together, this high rate of HIV exposure, as well as this plateauing potentially of infant and under 5 mortality declines, I think we need to stop for a minute and consider whether there is a contribution to infant and child mortality that we're not really taking into account, and what the effect of HIV exposure without HIV infection might be. Also, I want to emphasize that although we've seen a huge decline, our infant and under 5 mortality rate is still very high compared to other equivalent settings, and that all children in this setting are vulnerable. And what we really don't understand well is how well HIV-exposed uninfected children compare to HIV-unexposed children experiencing similar nutritional, environmental, and social constraints to their health. So the aim of this was really just to very simply try to start to understand the potential impact of this excess morbidity and mortality in HEU infants on the public health sector in South Africa. And so to do this, I just very simply estimated attributable fractions and population attributable fractions of morbidity, but essentially hospitalizations, as well as mortality due to HIV exposure without infection. And then also tried to estimate the annual excess hospitalizations and the annual excess infant mortality due to HIV exposure. So I won't go through the details of the various formulas, but I did need to make some assumptions about the number of births annually in the country, and the HIV incidence in infancy, as well as what the baseline risk for hospitalization would be in HIV unexposed infants to compare to. And then in terms of infant mortality, to make some assumptions on what the actual contribution of HIV infection is to our infant mortality rate. And that was informed by the recent CHIP data. So starting with infant hospitalizations, what is shown here, and if you focus just on the row that's bolded, this relative risk of 1.5. So this is informed by studies in South Africa as well as in Mozambique that have shown a 50% increased risk for hospitalization in the first year of life in HIV-exposed uninfected compared to HIV-unexposed infants. And if we look at that row, the population attributable fraction of 33% means that in HIV-exposed uninfected infants, 33% of their hospitalizations are occurring above and beyond what we would expect all infants in this setting to experience hospitalizations due to, and is due to the consequences of HIV exposure. The population attributable fraction, the next column indicating 13%, looks at in all HIV uninfected children now, both HIV exposed and unexposed, what is the excess hospitalization that is being experienced due to HIV exposure. So removing the background rates that we see in the HIV unexposed infants as well, what is the contribution of the consequences of HIV exposure? And that is around 13%. And then applying that to some assumptions about what the baseline rate of hospitalizations are, if we have to assume also from other South African work that about 12% of infants are hospitalized at least once within the first year of life. This would result to about an excess of 17,000 hospitalizations due to HIV exposure without HIV infections, in a total of about 140,000 hospitalizations in the first year of life in South African infants. So I want to stress that the 13% and the 17,000 are not the total contribution from HIV exposed infants. This is the excess above what the background rate is for all HIV uninfected infants. This is the excess on top of that due to being born to an HIV infected mom. The other two rows with the relative risk of 1.1 and 2 just show alternative scenarios. So if the increased risk for hospitalization is only 10%, then the population attributable fraction would be closer to 3%, and the excess hospitalizations would still be around 3,500 a year. And then if we had to just make a different assumption about the baseline rate of hospitalizations in HIV unexposed infants, so if actually only about 8% of HIV unexposed infants are experiencing hospitalization, then the excess in HEU infants, the fractions, the proportions remain the same, but the total number would be lower at about closer to 12,000 if the risk is 50% at a risk ratio of 1.5. So moving to mortality, the risk ratios here come from that meta-analysis I showed you at first, and the 1.7 is the risk ratio that they saw. The 1.3 and 2.2 are the lower and upper bounds of the confidence interval that they calculated in that meta-analysis. So if we just zone in on that row of relative, the risk ratio of 1.7, we see then that the attributable fraction just within HIV-exposed infants, the contribution of HIV exposure to their total mortality is about 40%. In the entire population of HIV uninfected infants, including HIV exposed and unexposed, this is about a 17% contribution of HIV exposure to infant mortality. And applying that to the rate of infant mortality, potentially in excess of 4 per 1,000 infant deaths. Assuming different, so that first scenario I showed you was assuming that at the moment we're seeing as little as 15% of the infant mortality in the country still occurring from directly from HIV infection. This is then looking at different scenarios. If the contribution from HIV infection is larger at 20% or then 30%, what would this look like? And we see then, obviously, as the contribution of HIV infection increases, the actual excess deaths and the excess contribution to the mortality rate does go down to 4 or 3.5 excess deaths per 1,000 infants. So on the pie on the left-hand side is just showing you actually from the CHIP data the under 5 mortality rates, causes, and I've been talking about infant mortality, but it's just to illustrate the an example that when we look at the major players of under 5 mortality, pneumonia, diarrhea, septicemia, and their contributions, and we compare this to the 17% excess that we're seeing potentially from HIV exposure without infection to the infant mortality rates, I think we do need to potentially look at this in more detail and stop and consider how we might actually better monitor and find better data to better inform what the contribution is to infant and under 5 mortality from HIV exposure without infection. Just going back to that, just considering what the contribution might be to that plateau in infant and under 5 mortality. So I want to just stress in closing that all infants in South Africa are vulnerable, that this is certainly not about prioritizing one group of infants over another group of infants. But HIV exposure without HIV infection does seem to be a substantial contributor to infant mortality and morbidity in high HIV burden settings. In South Africa specifically, this could be potentially up to an excess 17,000 hospitalizations and an excess 4 deaths per 1,000 infants each year. It is absolutely essential to reinforce optimal maternal health through effective antiretroviral therapy in HIV-infected women, as well as better uptake of safer breastfeeding. But there is evidence within this group that those are not the only 2 pieces to this puzzle of their risk for morbidity and mortality. Up until now, local and global monitoring systems have not made any attempts to specifically identify and monitor this population of infants. And I think we've heard this morning about the real strength and the pioneering efforts that have been made in South Africa with perinatal and child mortality monitoring and auditing. And I think we can definitely, each one of us individually can move to strengthen those monitoring systems by just coming up with consensus on how we use terms such as HIV exposed uninfected, and HIV uninfected, and what we mean by those terms, and using them with greater precision to identify within our existing monitoring systems this population of vulnerable children more specifically. Thank you, and look forward to your questions.
Thank you so much, Amy. Questions for Amy? There's one at the back.
Good afternoon. Thank you. Do you think that your increased mortality in HIV-exposed kids is due to a confounder such as the children having a sick mother or
Right.
socioeconomic deprivation correlating with HIV exposure? Or do you think it's a direct effect of...
So I think for sure it's multifactorial. It's both of those. It's that group of universal risk factors that I just very briefly spoke to, that these children do have moms that are sicker, more often have moms that die early during their childhood, that we know that HIV-exposed infants have not received optimal infant feeding, have less often been breastfed, they are living in more impoverished circumstances. So what I'm showing here is really just that whole package, all of those, as you say, those potential confounders or those universal risk factors that they experience, together with these these are unique exposures of actually the viral exposure and the ARV drug exposure. There is work that's being done to try and really look at the potential of those confounding prospective cohort studies that have been done to look at HIV-exposed and HIV-unexposed infants in similar social circumstances with similar breastfeeding exposure, with moms essentially low-risk HIV-infected moms that are well, and there is still this difference. There's still this increased morbidity and mortality in those infants, even taking those confounders into account. What I was showing here certainly is that whole package, everything that it means to be HIV-exposed. I wasn't meaning, in this presentation, the direct effect of exposure to the virus. It's that whole package of exposures. Yeah.
Thank you.
Any more questions? One question from Rita.
Yes. 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 So I think, so in terms of the psychosocial impacts, I think there's actually quite a bit of evidence now that shows that HIV-exposed uninfected adolescents have poorer mental health outcomes than HIV-infected adolescents. Because the HIV-infected adolescents are often in a care system, they've got support structures, whereas those that are born in these HIV-affected families that are uninfected themselves are not within those support systems. So their mental health outcomes are certainly also a concern. And then in terms of neurodevelopmental outcomes, there's a lot of work being done to look at neurodevelopmental outcomes. It's challenging because it's across many different settings. Neurodevelopmental measurement outcome tools, there's so many and they vary and they're not always culturally and contextually appropriate. So interpreting that information at the moment is a bit challenging. But there is a lot of work being done in that area.
Thanks, Amy. Just for the audience, can you repeat the question because we didn't all hear it?
I can remember. I asked if there was any similar work being done around psychosocial and developmental impacts of HIV exposure on uninfected children.
Thanks, Vidad. If there's no burning questions, I think our time's over. Thank you very much to Amy.
Okay, our next speaker is a pediatrician from KZN.